learner's problem. We are here today to share with you how to handle these struggling learners' problems. We have Tammy Sohn from Washington University, and we have Laura Bacher-Lind from Tufts University, and I'm here from East Carolina University. We have no relevant disclosures or financial relationships to disclose. Learning objectives. Describe the most common concerns associated with the struggling learner. Construct an approach to remediation. Practice problem identification and plan development through cases. Review barriers to remediation and identify resources to assist with struggling learners. Part 1, assessment of the struggling learner. What types of struggling students have you encountered? Let's answer in the chat. What do learners struggle with? We want to kind of capture the scope of the problem. Throw it in the chat. Time management, lack of insight, efficiency, hierarchy, independent learning, engagement, communication with team members, critical thinking, the volume of information. You guys you're in the right session. We all have common problems. All right, let's see. I think we're ready. Triage, prioritization, professionalism, applying learning in different contexts. Fantastic. Take it, Tammy.
Awesome. Thank you. So just identifying the scope of the problem, right? So if we look actually at some of the data that we have now, this is a little bit older, but a 2006 study where internal medicine clerkship directors were doing an institutional survey, and about 83 different institutions responded. And at that time, up to 15% of students per year were struggling in general. And when they looked at who is it that is actually creating and designing these remediation plans, it was about 57%, in which it would fall on the shoulders of the individual faculty, meaning like the clerkship directors that were responsible for that. Here, when we look again at another way to look at the scope of the problem, this is the University of Colorado. And in this particular instance, they have, which is amazing, a remediation program. And so they looked at their trainees from 2006 to 2012. These were mixed learners, and trying to identify where the deficits were. And so if you look here at this table, we have in the bar graph medical students that are in the black lines. And here, when you look predominantly at where they fall, the mental well-being concerns, clinical reasoning, and medical knowledge were the three areas that were the highest. And though I think we think commonly of the latter two being areas in which there commonly are deficits, I think it is important to note how high mental well-being falls right in that realm as well. When we target residents or even our fellows, so residents are in the gray bars, fellows in the white, we're looking at areas and the deficit higher percentage categories that are around practice-based learning and improvement, PBLI, professionalism, that are the two highest. Others are also in that running, but those are the two highest. So just good to kind of make note of what we're seeing as trends, and being able to appreciate kind of, again, what type of deficits do we see across the board when people have reported on this.
Case 1. It is September, and one of the M3 clerks on your service is struggling. Student Smith is repeatedly unprepared for rounds. You note he arrives earlier than his peers, but spends his time inefficiently, has difficulty prioritizing who needs to be seen first. Important clinical things are overlooked. Presentations are disorganized and lack relevant information, and often he misses the forest for the trees. What are student Smith's primary deficits? Answer in the chat, put your A, B, C, D, E, whatever you got. And answers
you can put more than one. Yeah.
C and possibly F. We got some B's, C's, C, F, B, and C. All right, well, let's see what we have for you. We actually believe that there could also be issues with medical knowledge, yes, clinical reasoning, organization and efficiency, communication and interpersonal skills. And yes, we don't know if there could also be issues with mental well-being. So let's see here. What additional information do you need to figure this out? Let's see. Yes. Okay, so we have in the chat, what about learning about student perspective, their insight as to the first year course directors? All right, you guys are on it. How is he spending his time? Take it, Tammy.
Awesome. No, it's perfect. And so just doing a little digression into the mental health conditions and just highlighting again, this is information from the UVA. And basically when they were looking at their clinical performance deficits and reasons why, if you look on the left here, that pie chart indicates those who had mental health concerns, where those concerns lied. So anxiety and depression being common, 48% and 17% respectively. Cognitive dysfunction, 17%. Adjustment disorder, 13%. And then if you just looked at those who had mental health concerns, of which it is 38% that had that, you're looking over here on the right to see kind of in what deficit areas did they most commonly lie. And so here you're seeing professionalism and clinical reasoning, those two things being kind of at the highest when it comes to those areas in which those with underlying mental health concerns seem to have the most issues or concerns. So here we have, just going to take some examples of running through the thought process a little bit about some of the, I would say, pretty common things, although there's so many different things that we see. In this particular case, we have a learner who's disorganized. And so if we think about a differential diagnosis for a disorganized learner, we have then true organizational problems. Absolutely. Maybe this is something that's a global problem. Things that can give you indicators of this if they show up and it seems like, you know, their workspaces are always very messy. They don't appear that they have just other things in their life organized. Maybe you might even inquire about how they're doing in terms of just like, are they able to keep up with other life things, whether those are bills, et cetera. Maybe they are just unfamiliar. They can't adapt to the EHR. They seem really very unprepared. And these are impacting other areas, not just their clinical medicine practice. Then you might also then have true just focal clinical reasoning deficits in an otherwise organized person. And so this is what I feel like we classically see a lot. Those that were mentioned in the chat, lacking illness scripts because they can't seem to identify or put things together effectively. They can't seem to create a one-liner or triage information, these types of things. And then the ever-present issue with mental well-being being just kept in that awareness level that in fact, this might be stemming from a root problem in this arena as well. Another one is that chief complaint that the learner is always late. And so here, when we think about being late, sure, it can be, again, time management that's a problem. It could also be around professionalism that actually might be the concern here. Maybe they just don't think that being a few minutes late is a problem or don't recognize that. Or again, it could lie in the arena of mental well-being or some kind of impairment due to substance abuse or a narcolepsy related concern. We can come up with many other things along that line. And then the final thing here is around the learner that can't reason. And so a clinical reasoning deficit, again, missing the forest for the trees, difficulty with those patient presentations. This list goes on and we kind of have a good sense of where that might lie with any level of our trainees. But we're going to talk in a moment now about how we can organize all of these different evaluation concerns that we see.
Great. So thank you, Tammy, and thank you, Jill. So I'm moving on now more to the assessment of the struggling learner. So those are some common scenarios: a student who's always late, a student who's disorganized, a student who can't reason. As Tammy mentioned, there's a host of other kind of illness scripts that can be used in a sense to apply to a struggling learner. Those are just 3 of the most common. However, it is important to correctly diagnose the learner. So when you have a student that's struggling, before we can even talk about how to support that student, how to implement a remediation plan, we really need to be very confident that our diagnosis is correct. And so how do we do that? How do we get more information to make sure we really understand the struggles of the learner? If that learner is coming from prior clerkships, prior programs, if you can go back and look to see their undergraduate performance, but trying to really understand historically where this student is the trajectory of their struggles can be very, very helpful. Talking to people directly who have worked with that learner. So if you're getting feedback in an evaluation form about a learner's struggles, also follow up and speak with that faculty member or track down that resident and try to get a little bit more insight as to what happened and how they determined, how they came to those conclusions. Getting specific examples is really helpful, not only for you to understand the problem, but ultimately for you to be able to get some buy-in when you're talking with your learner. Yourself, if you've worked with the learner, your insights are invaluable. If you haven't yet worked with that learner, trying to go out of your way to schedule that learner to work with you in the office, to drop by on labor and delivery and see how they're functioning on labor and delivery, assign them to your OR case that's coming up later in the week, but trying yourself to get some direct observation can be really helpful. And ultimately, like you all pointed out when Jill asked, what do you need to do next? We need to meet with the learner. We need to sit down with the learner and get their insights, their perspectives as to where they've been struggling, and also for you to be able to evaluate for mental health issues that could be certainly complicating the situation, especially these days. When you meet with the learner, again, you're going to be asking them, you posed in the chat, several of you, questions that you would start with. What are your perspectives of how things are going? A nice open-ended question to get that insight. Ruling out the underlying factors, asking about sleep habits, substance abuse, depression, anxiety symptoms. You can ask about these things as an educator. And then performing a review of competencies plus, it's a review of systems. So just using the analogy of diagnosing a learner, we also want to conduct a review of systems to make sure we're not missing anything. Maybe it didn't come up, but it still remains a problem that needs to be addressed. So using a competencies plus framework for that, which we'll get to in a moment. So moving on to the development of the remediation plan. So remediation is commonly now being looked at through a coaching model. So oftentimes we are assessing using a multimodal assessment, kind of what I just went through with you, whether it's evaluation form, supplementing that with direct observation, supplementing that with conversations with people who have worked directly with the learner and historical perspectives. It's also fed into by any mentors or coaches that a student might already have. I know that at Tufts, where I am working, our students are assigned, we have a coaching program. So the coaches do have some invaluable insight as well that can ultimately help a student and diagnose that deficiency and develop a remediation plan to help boost up where those deficiencies lie. Once a learning plan or action plan is developed, it needs to be implemented. And so putting out there what is going to be done specifically to remediate this learner, whether that's deliberative practice, whether that's an reading curriculum, getting feedback as that is happening, and having the student continually reflect on their own progress is key. And that can further be augmented by more input from the mentor or coach. Ultimately, if everything goes well, this would lead to, sorry, I'm having a tough time seeing the bottom because of my chat. There we go, to a certification of competence so that the student, the learner ideally would ultimately be graduate, so to speak, from this remediation program when they've attained the goals that they sought out to attain. So the first steps in this are to, again, meet with the learner and then really try to fully understand the situation, both from their perspective, as well as running through your review of systems. So when we think about the review of systems or the competencies plus, they're listed here, but really being thoughtful, thinking about the students' medical knowledge, their patient care skills, including clinical skills, reasoning, time management, their communication skills. A lot of you mentioned in the chat that you struggle with students who have interpersonal and communication challenges, professionalism, system-based practice, as well as PBL improvement. And then, of course, not to be overlooked is mental well-being, screening for those substance abuse, sleep, and mental health issues. So what are the next steps once you have gone through your review of systems, you've really thoroughly diagnosed the problem, haven't left anything unaddressed? Once you figure out what those problems are, we need to select a mentor or coach, somebody who's going to oversee the remediation plan. It doesn't need to be you, it depends on your role in the program, but it may be the clerk group director isn't the right person for this, and it should be somebody who's a little less engaged and potentially a little bit more of an advocate, on the student side. That's to be determined, but you can pick a mentor or a coach to oversee the remediation program. The deadline, the time frame at which follow-up evaluations are going to be held, and the consequences if goals are not being met need to be really clearly laid out from the start. An assessment really should occur quite frequently. We don't want too much time to pass without having regular check-in points with the remediating learner. Documentation is key. We do know that, that flow sheet that I showed you before, we do hope that learners get to the point where they can demonstrate competence and graduate from the remediation program. Sometimes that doesn't happen, and learners, despite a well-done remediation plan, a lot of support, engagement from the learner, still may not achieve the outcomes that are needed to stay in the educational program. And oftentimes, if a resident is let go from their educational program, there's a lot of legal consequences that can fall out from that. So documentation is key. It's important to make sure that the learner is privy to these documents, even having them sign off on them to show that they're engaged, they were aware of the deadlines, they were aware of the measures that were put in place to measure progress, can help to remediate or to mitigate any legal consequences from these kinds of decisions. So this is an example of a competency improvement plan or a remediation plan or an action plan. There's different terms for them. This one is already filled out. There is an example of this. We have a PDF that you can access. It's in the resources section of Whova. So please feel free to access that and to use that with your struggling learners. And you can see here the learner's name is up top, as is the mentor who is selected to oversee the program. In this example, it's a monthly interval for follow-up visits, but it can be different. And then this is where you would put down in the first column there where it says, what is the deficiency? That's where you would clearly write down what you have determined the issues are from your review of systems, where you would put down what the goals are or the deficiencies are of the learner. In the next column, what must happen now? Very clear, specific interventions. So these should be behaviors, curricula that are going to be implemented to help address the deficiency, as well as the measure of success in that final column. And so that is where it needs to be a clear and measurable outcome, not just learn something, but demonstrate something. And so that needs to be clearly delineated in that last column. Okay, so we're moving now onto our small group exercise. And so this is a breakout session that we're going to all get you talking and interacting on, talking about your struggling learners. There are 3 cases. Dr. Sana is going to put them up in the chat. And so you can, you're going to be assigned a case. So please pay attention to the group. You're going to get a group number and then click on the group number. That is the case of the group number that you're assigned to. That will take you to something called Jamboard. And Tammy will talk with us a little bit more about how to navigate Jamboard. But that's where you'll see your case and interact with it both as a group and then with the document itself. We will then reconvene after about 10 minutes, and we'll go through the cases. Please select somebody from your group to be the speaker so that that person knows they're going to be put on the spot and can share the group's conversation. The questions we ask you to address are three. First, after you read your case, what are the underlying factors of this struggling student? Come up with a diagnosis for that learner, and then brainstorm the most important parts of a remediation plan.
Perfect. So just real quick, this is what the actual Jamboard looks like. I know many of you are already familiar, but a real brief introduction in case you are not. So this is just showing you, for example, if you happen to be in a breakout room, you see it flash up real quick. I always forget what number, so emphasizing what Laura had said, just remember what group you're in, and then being able to click in the chat. That chat should still stay live when you go into your breakout, so you can then click on that link. So this is group 1's case. You're going to read that case and then have, sorry, it's in a weird order to make things fit, 1, 2, and 3, those 3 questions we just briefly mentioned. You're going to have a text box on our left nav bar over here. And so if you wanted to click on a text box, you would just go ahead and click. You'd have that text box. You can go ahead and type whatever you want. And then you're going to, if you go away from that, but then want to re-edit that, the 3 little dots at the top can let you then go back and re-edit anything else that you wanted to say. You can delete it. You can then click on it and just move it around wherever you want. So everyone actually clicks on that link, and everyone has a live link that you can just all participate. There's, in our group's going to be roughly about 5 people per group, and you'll all be able to write your thoughts down there as well. If you want to delete it, just come over to those 3 dots again and delete. You can also get super fancy and put photos in there if you would like, but another common one are sticky notes. And so you click on this little icon, it's a sticky note, write whatever you'd like, and it's in pretty colors. And so here you have, again, the 3 dots above to edit or then to delete. If you don't have enough space, I'm sorry, these are very crowded slides. Just remember up here, this is basically a slide deck. You can come over here and toggle over if you want to have a blank sheet to look at. So when we come back to debrief and discuss, I hope you guys can assign a person to be our announcer, but we'll go through at least all the 3 different case types, and then we'll be able to see your thoughts and notes that you've been able to write here. So yay, with that, let me go ahead and just get us into our breakout rooms.
I think it was a Hooba thing because I could see it in my chat because we're in this side of Zoom. But
yeah, okay. Not quite sure. So we're gonna just go ahead, and Laura's gonna take us off here in a second to our debrief here.
Debrief, perfect. So I was hoping to have a few volunteers. I know we had quite a few breakout groups, so I won't necessarily get every group to speak up or we'll run out of time, but maybe if I can get somebody to speak up from each struggling students group. Could I have a volunteer from the Andy groups? I think that might be 1, 2, and 3.
I can share what our group came up with.
Right.
So which one is your
This
group?
is from the Andy group. And we're going to tackle the 3 questions of the underlying issues, diagnosing the learner, and a basic remediation plan. Thank you, Sybil.
Do you want me to read the case, or is that?
No, actually, I'm going to pull it up on the screen. Which group are you? 1, 2, or 3?
1.
Awesome. Can everybody see that?
Mm-hmm.
Okay.
Yep.
Yeah.
Okay, so so for what is the deficiency, we identified a few possible deficiencies. The first of which was just clinical reasoning, just Andy's inability to, see the forest for the trees and develop a succinct differential diagnosis, and then like putting everything together, which may be more of an organization problem. And then the case also talks about how Andy feels appears very anxious presenting patients in front of colleagues and peers. So perhaps there's a bit of a mental health anxiety, like performance anxiety component.
Mm-hmm.
And then in terms of what must happen now, like always, we thought we needed to meet with Andy and talk about some potential ways to address these issues, specifically doing some case-based learning with him, doing some illness scripts, employing visit templates, and then setting specific time goals with him. Like if he's rambling in a presentation, just, present this patient in X number of minutes. And then in terms of wrapping it up, like, how do we know if we have, accomplished anything? Completion of assignments, meeting time goals. So, just, following up with Andy, like, is he getting his H&Ps done on the time goals that he's set for himself? And then also just doing a little self-reflection, like asking him, like, do you feel any more comfortable during your presentations with the increased exposure? So that's what we came up with.
Great job. There's a lot of strengths, a lot of things that Andy has going for him, I think, that are going to help him, right? He's receptive to feedback, lots of positive comments about knowledge-based interpersonal skills. So he seems like somebody who has a high success of being able to remediate and getting on the right track. Although if he does indeed have anxiety, which I think is something that you astutely pointed out could be part of the issue here, as you point out, as far as the determination of success, making sure that he's managing his anxiety, that if it's not something that he's aware of, or if it's a true diagnosable problem, that he's getting the support that he needs, and working with your Office of Student Affairs to make sure he has access to that evaluation and care if he needs it. Anybody else from any of the Andy groups want to chime in with anything that your teams thought that maybe a little bit different, or in addition to what group 1 came up with?
This is Jonathan. I'm in group 2. We also had Andy, so I feel like we hit most of the same conclusions and agreed on most of those things. Also, we had discussed before about having a mentor or coach assigned, and somebody who could sort of take a direct role in sort of giving pointers on taking a history and physical in an efficient way, and perhaps providing those scripts and templates. And then that could also be somebody who is the person to supervise them and directly observe to look for improvement afterwards as well.
And this is in my program, we use an education chief resident a lot for this. So we have a 4th year who we chose as from the other 4th years because of her or his interest and skill with educating medical students. And oftentimes that resident, we will sometimes pair with a student to have more regular feedback. As a clerkship director, sometimes students don't want to necessarily talk to me about mental health conditions and issues, but sometimes they do with a resident. It seems a little bit less threatening. Okay, great. So let's move on to our Julia cases, our Julia teams. Does anybody from a Julia team, that's teams 4, 5, or 6, want to speak up about what your group worked on?
Hey, my name's Lorene Timming, and we were in group 5. I don't know if you can pull that one up.
Oh, so look at all those colorful sticky notes. I love it.
Couldn't figure out how to make the text box work very well, but Julia is a 4th year sub-I and basically has an interaction with a antepartum nurse about an order for labetalol and whether or not to give it to the patient, and the nurse perceives her as being a little bit confrontational and rude in that interaction. And then the background is that Julia completed med school somewhere else. So we talked about just thinking about kind of the underlying factors that there could be. This could just all be related to communication style and cultural differences, that we would also want to talk about kind of the non-cognitive attribute of collegiality with her, and then just kind of extrapolating from that background, make sure that she's not under some kind of psychosocial stress related to her support system not being here in this country, although that makes some assumptions. So we would want to check in about that. And so in terms of the differential diagnosis, basically we'd be working on communication and professionalism, and then making sure that mental well-being is not an issue. Also, I should say in the case it, pretty well says that she has a good medical knowledge base. So in terms of a plan, the deficiency being professionalism and communication, we would meet with the students to discuss means of communication. Like, sometimes when things are happening over the phone, they can be misinterpreted. You could advocate for going face to face, that depending on, where you are, and even where in the United States you are, the communication and how it's perceived might be different. You could consider doing role play with the student as a method to practice. And then also, I think important to seek feedback from other team members about the student, because maybe this was just, the middle of the night and a bad day, and maybe the nurse was having a bad day too. So, not necessarily saying that there's a systemic problem if there isn't. And then continuing to get feedback from the nursing and other team members going forward, and asking the student kind of how they think it's going, and setting up from the beginning kind of timeframes that you would meet back with the student and check their progress on the issue.
And one thing, as far as getting that continued feedback from nursing and team members, since we are on a deadline, sometimes being more targeted too, setting up an expectation that nurses can be surveyed, whether formally or informally, at a certain time frame to get their input. I think Jane wanted to comment, and I don't know if any other Julia teams also wanted to comment. Jane, was it you wanted to add something about this case?
Yes, so we're in group 4, and we identified that Julia is on nights. So we identified fatigue as a possible impairment that we wanted to bring up with her. And it seems to be sort of a departure from her normal, very good medical knowledge. So we wanted to evaluate whether Julia's schedule is such that potentially she's suffering from fatigue, and whether her schedule needs to have some mitigation in it for fatigue.
Mm-hmm. Excellent. Okay. Perfect. I want to make sure we have time for our last case for the Kathy team. So thank you for the Julia team members who spoke up, and let's solve the Kathy case. So anyone from the Kathy case that is willing to speak up from your group? And that's groups 7, 8, and 9. Laura Mercer.
Yes, I can. We were group 7, I think.
Okay.
And so the background of Kathy is that she's an intern, and she's enthusiastic, but has potentially a fine tremor, and has gotten feedback that really her surgical skills need quite a bit of work, and potentially that she lacks confidence in her abilities. So we actually felt like we needed a little bit more information about things that could be going on with Kathy. So we identified a few potential underlying factors, including psychosocial stressors or potentially some kind of impairment. Fatigue, as we just talked about, could be part of it, but we also talked about caffeine or other medications that could lead to a little bit of a tremor. We weren't sure if preparation might be part of it, or if perhaps she's having trouble connecting the dots from feedback to the mechanics of what she should do next. So we really honed in on talking with her and meeting with her about her experiences, and then putting in a plan for maybe some direct observation with core faculty or selected faculty that really have skills in teaching in the operating room environment, and then looking for opportunities for simulation and practice for her so that she can build up those confidence and skills. We wanted to make SMART goals with her and engage her in that goal setting process, and then really look and plan for some frequent formative feedback. We also talked potentially about implementing something like a surgical passport to help her catch up and meet those surgical milestones.
Excellent. Yes, SMART goals are always that, it's kind of the measurable, specific, and also timely. So having those deadlines in place, those are definitely a great approach to coming up with those determinations of success. Thank you, Laura. Anything anybody else from the Kathy cases wanted to add?
I just wanted to share Neda from our group had this brilliant idea, which was sort of assigning her like a surgical skills coach, someone who she could meet with, who she could identify areas that she wanted to work on. They could go to the skills lab together as kind of a safe place for her to practice, and then could frequently check in with to see how she was progressing. And then that individual could also potentially provide feedback to the CCC or to the PD about, which I guess that is a mentor, not a coach if you're giving feedback, but about how Kathy is doing in a little bit more objective way as well.
Great, yes, but having the idea of somebody who's designated to kind of oversee that rather than getting snippets here and there can be really, really helpful. Perfect, so let's kind of go back to our big group presentation. Thank you all for your contributions. It sounds like there were some really dynamic conversations.
All right, there can be some barriers to remediation, and we're going to move quickly. There are always the challenges of resources, whether that be faculty, expertise, or additional teaching sites, stigma for faculty and learners to be involved in remediation, fear of legal reprisal, or fear or lack of clarity on institutional policies surrounding remediation. Institutional strategies, we can be very explicit about the requirements that would trigger remediation. We can use teams to execute those plans, define probation, educate faculty on legal status of a failed remediation, normalize remediation as the part of the learning process, and align learner selection and assessment with the desired outcomes. For faculty strategies, we could standardize documentation, use templates, provide faculty development to support early identification of learners, effective interventions for remediation, assessment of improvement. We can use multi-source feedback, and we can establish a robust culture of feedback. For learner strategies, early detection and clear communication with the learner, assess for external stressors, initiate remediation plans early, notify learners of multi-source feedback strategy, engage learners in the remediation, feedback sessions, scheduled check-ins, reassessment, and a timeline for improvement. Lastly, we got resources. Take it, Laura.
So these are two fantastic resources, some of which have been referenced in this talk, but remediation of the struggling medical learner, Jeanette Guaracio is really the probably most renowned person in this arena. And this is a pretty medium, thin-sized textbook, easy to get through. So that's a fantastic resource for you, as well as remediation in medical education, which is put out by a more collaborative book, more like a traditional textbook. But those are both fantastic options for you. Lots of resources here. These are different papers, publications that you can access. These slides are available to you in resources, again, on the Whova app. So please feel free to look into them and also to connect with us. If you have any other questions or struggles with your struggling learners, we're happy to help.
We now have a few minutes actually to entertain any additional questions.
Thank you for working with us in our little kerfuffle moment earlier. So thanks, a lot of you guys created workarounds. Appreciate all the ingenuity there. So thanks for bearing with us too. I just want to highlight that in case it's helpful. Again, I know that the handout section in Whova can be a little bit like weird because you kind of have to end up opening every single thing up. But when I just have samples there, we do have, if it's helpful, just to have honestly what is an Excel spreadsheet of a document that Laura was talking about earlier, of having that documented, templated form for where there are concerns and issues in your game planning of what that looks like. We have a handout specifically that has then the list of underlying factors and that differential diagnosis, if it's just honestly helpful to have on hand to be able to go through that as you deal with struggling learners that come your way. So hopefully those two specific documents might be helpful. And then if you're doing faculty development, feel free. We had copies of those 3 different cases. If you want to take them, use them, feel free. We have that evaluator version of really honestly what you had in that slides also on a handout format.
So we have some questions in the chat.
Yes.
Jane's question is really important. What do we do when we have only these learners in our space for 6 weeks or less, and we have to make these changes on a short-term scale? How do we handle that? Then another question after this.
Yeah, so to me, Jane's question and Sarah's question are very similar. The idea of the students move through our arena so quickly that it's really hard to diagnose and implement and follow through with anything with a learner. To be honest, I don't know if you really effectively can in isolation. So that's where some institutions feed forward. My institution does not, but I know that Elise Everett up at UVM, they do. So for instance, a prior clerkship, a student's struggles are kind of given in a dossier, so to speak, to the next clerkship director. Whereas where I am at Tufts, every student starts from scratch every clerkship, and there is kind of rationales and advantages to either. In an institution like mine, where I don't have that insight, I only have the brief 5 or 6 week snippet. I oftentimes will feed information back to the Office of Student Affairs, where there is a longitudinal system in place to address these very issues. So I'm actually part of even a bigger conversation for remediation with struggling learners. That being said, occasionally I have had learners, even within a 6 week rotation, if a problem is identified early, people email me, let me know that a student seems to be struggling, I'll make a meeting with that student ASAP before even a mid-clerkship meeting comes up to talk about the issues that have been brought to my attention. And then we'll, depending on what it is, come up with that plan. Well, this is a problem. This is what we need to work on to address it. I'm going to meet with you again at the mid-clerkship. And then even a week later, I want to meet with you again. So sometimes you can implement something in a short time frame as well. But it's really important to be speaking to the Office of Student Affairs or somebody who will see that student more longitudinally as well. Anything to add, Tammy or Jill?
Yeah, I like that. I really do appreciate it. We also are not technically feed forward, but when I do have the occasion where centrally somebody else has then come to me and said, hey, and it's not like something that's, well, no, it's just you as the clerkship director know what the specific issue is. It's really helpful for me then to understand what that is and figure out how to game plans and work towards a plan that kind of carries over from before. So yeah, just echo that.
And one other question in the chat from Meg was about, what about someone who's perceived as being very direct? And how do you handle it when it comes across as more of a personality difference versus, a cognitive difference, And then lends itself to potential for gender bias too, if women are straightforward versus if a man is straightforward.
Mm-hmm.
I don't have a solution for this. Any wisdom from Tammy or Laura?
This is a situation where I'll try to work with a student myself, or also make sure that I'm getting a lot of feedback so that if it is one person's bias, that I'm not echoing it and amplifying it. Mm-hmm. But it's kind of like what we were talking about at the clerkship director school yesterday, is that you are judged sometimes by your patients from one brief interaction. So even if a student is rubbing somebody the wrong way or giving off a certain vibe, that is something that student needs to be aware of, because it might be something that does impact them down the road. So if that's the case, I usually will try to neutralize the feedback in a sense to get the exact verbiage that was given to me and say, this is somebody's perspective. Take with it what you will. But you should be aware that this is how somebody saw that interaction that you had with them, and just be aware of that going forward.
Yeah.
I also might just do a quick plug and say, just Dean of Student Affairs for me is my direct contact to figure out if this is something that's just specific to our nature of what we do in our field and our, is it something that's ongoing, just to get a better sense if this is really something unique to us, unique or really kind of an ongoing issue with that particular learner. I know we're out of time here, so yeah.
Thank you.